Welcome to the BioAfrica Convention and to our session this morning on improving cancer patient outcomes in Africa through cross-sector research collaborations. My name's Jennifer Dent. I'm the president and CEO of BioVentures for Global Health, a nonprofit organization based in Seattle, Washington. And today, due to really the dramatic reversal of longstanding health trends, cancer kills more Africans each year than malaria. So we're going to be speaking about partnerships across government, industry, academia, nonprofit sectors that are addressing Africa's cancer crisis by improving healthcare infrastructure, building clinical oncology capacity, expanding research and clinical trials focused on African populations and settings. So we have a number of impressive, experienced panelists with us today that represent different sectors, all committed and working to improve cancer patient outcomes in Africa. Mr. Uche Orji is the Managing Director and CEO of the Nigerian National Sovereign Investment Authority, or NSIA. Mr. Orji will be speaking about investing in state-of-the-art infrastructure and international collaboration to take on cancer in Africa, and specifically about a new cancer center that has been built by NSIA in Lagos, and the plans that NSIA have to expand and build more hospital and cancer infrastructure in the country. We'll hear from Dr. Chris Reddick, Vice President of Global Patient and Scientific Affairs at Takeda Pharmaceuticals. And Chris will talk about how Takeda is leveraging the company's employee expertise to support Africa's cancer control priorities and address Africa's cancer crisis through research and development partnerships and training. And we have Dr. Francois Uwinkindi, the manager and head of the NCD division of Rwanda Biomedical Center, or RBC, working under the Ministry of Health in Rwanda. And Dr. Francois will speak about how his team is working to deliver Rwanda's National Cancer Control Plan objectives through research and driving international partnerships. And Dr. Peter Kingham, who is the director of the Global Cancer Disparities Initiative program at Memorial Sloan Kettering Cancer Center in New York, will speak about the partnerships he's established and that are working toward co-developing novel technologies that will diagnose cancers in low and middle income countries, and specifically a research program focused on colorectal cancer. And so we'll start by playing the recordings of the speakers, and we look forward to taking questions and answers at the end of this session. There's no volume currently. We need sound on the video.
There's no sound.
Yeah, you'll have to start the video over of Mr. Orji and with sound, please.
Today we're talking about cancer treatment in Nigeria and investing in advanced equipment for cancer treatment in Nigeria. The reality about cancer treatment in Nigeria is that it has affected so many lives, and the sad part of the whole issue is that most of it goes underreported because the registries are not well structured. But over time, we're seeing a higher and higher incidence of medical tourism, where up to 40% of the medical tourism in Nigeria is as a result of cancer and cancer-related issues. And this gave us an incentive to invest alongside the Lagos University Teaching Hospital in building the first advanced cancer treatment center in Nigeria with some of the most advanced equipment. The lesson here has been quite fascinating. On the one hand, and sadly so, we have seen a significant increase in the number of people who have needed the services. On the other hand, also, we've come to realize that the dual challenges of not being able to afford some of this treatment, as well as a broad need across various parts of the country, calls for an innovative way to actually providing this service across Nigeria. One of the missions we have set to ourselves at the Nigeria Sovereign Investment Authority is to invest in cancer treatment as part of our healthcare portfolio and healthcare strategies. My name is Uche Oje. I'm the CEO of the Nigeria Sovereign Investment Authority. 4 years ago, we laid out our strategy in cancer care. Before I go into that, let me speak to you about who the NSIA is. The Nigeria Sovereign Investment Authority is the sovereign wealth fund of Nigeria, and we manage assets that invest both domestically and internationally. There are 5 sectors that we have set ourselves to invest in our domestic investments. Those are healthcare, roads, power, agriculture, and gas industrialization. These sectors, along with other sectors in infrastructure, at the moment have been allocated 50% of our assets. The other 50% are invested in our savings funds for future generations, as well as our stabilization fund. Most of that is invested internationally. Our mission is to provide a savings base for Nigerian people, as well as invest in enhancing domestic infrastructure. Currently, our assets under management is about $2.15 billion. Like I mentioned earlier, 50% of that is committed in infrastructure. Again, how do we decide what to invest in? We look at certain criteria. The first is whether this sector is of national importance, and we can all agree that healthcare is of national importance. The second thing is, can we balance social and commercial returns? And we have made a very good effort at balancing it, and our test cases of our 3 investments so far in healthcare have shown us that we can balance both. The third key criteria for us is, can we attract commercial and can we attract international and local investors? And we have been able to successfully do so in our healthcare investments, and we're looking to do more in the future. And then finally is, do we have a conducive and legal and regulatory environment? Healthcare, in the way we have gone about it, checks all 4. We believe that we can balance both commercial returns, bring in foreign and local investors, and work within a conducive legal and regulatory framework that allows us to deliver value for the Nigerian people. When we went into the healthcare sector, there were just some really stunning sets of numbers. The first is obviously the fact that the other infrastructure necessary to make payment easy hasn't really been fully developed. And as a consequence, 72% of spending is out of pocket. This obviously limits the number of people who can access care, given the high cost of some of the necessary equipment for treating things like cancer in a place like Nigeria. As you can see in the statistics I provide out there, there are just so many factors that make it really difficult for people to pay for it. We are 200 million people almost, according to the recent estimates of our population. But the reality also is that less than 3% are covered by adequate health insurance, which makes it a relatively difficult market. And we're hoping that most of this other infrastructure can improve in order to address the needs and make it easy for people to pay. How does the NSIA choose to address the healthcare sector? There are 3 parts to our strategy. The first part is investing in tertiary healthcare solutions. And here we're partnering with teaching hospitals, federal medical centers, and other agencies of government to provide institutions that will drive that level of care. The second is investment in medical manufacturing. This is an area where we are developing at the moment. We haven't really made any big investments yet, but we're hoping to start off with pharmaceuticals in this area. The third is diagnostics. We believe that diagnostics is one area that there has not really been a significant adequate investment in the country, and we are beginning to make inroads into this area. We have recently this year commissioned 2 ultra-modern, significantly high-capacity radiology and diagnostic centers, all of which we believe will complement other investments that we're making in healthcare. Why do we care about oncology? So many reasons. One is about 70% of global deaths in cancer occur in low and middle income countries such as Nigeria. Many people are dying in this country, and quite frankly, in my personal survey, there's hardly been anyone within my circle who has not been affected one way or another, either directly or indirectly by cancer. Too many people are dying needlessly for diseases that could be diagnosed early and treated early. The second reason is just how much it's costing by way of resources of people that go abroad for medical treatment. And it's quite painful to watch this amount of money getting spent when Nigeria has one of the most sophisticated healthcare professionals who just haven't been able to practice at the highest levels of their profession because they do not have the equipment. These are the reasons that makes us care about oncology. 40% of medical tourism is related to oncology. I'll go to the next page and look at the most common cases. The most common is breast cancer, very high level of breast cancer occurrences. The next is cervical cancer, and then prostate cancer. These are some of the areas where you're seeing significant incidences across the country. And we believe that we can play a meaningful role here in prolonging prolonging people's lives and making sure that there is equipment and tools for treating these areas of challenges for people. Among Nigerians, the high incidence of prostate cancer, especially among Nigerian men, it's something that has become a significant area of concern across the country. And we have actually identified this as an area where we're going to make sure that significant investments are made. And of course, like I mentioned earlier, both breast and cervical cancer issues are at the moment very, very challenging for Nigerians. If you look at the female occurrence of cancer, breast and cervical cancer constitute 68% of the incidence of cancer. And in the case of men, prostate and colorectal challenges constitute something in the order of over 60%, over almost 70% actually of cases in the country. The first major investment we made is in the Nigeria NSI Luth Cancer Care Center, which is Luth is a Lagos University Teaching Hospital, which is probably one of the most advanced in terms of cancer care in the country. It was a very challenging project, but we worked together with Luth to pool our resources together with the NSI, investing on a PPP basis with the teaching hospital to build out this facility. The essence of this facility is twofold. One is to make sure that we build the best quality cancer center, provide care. It will be run profitably, and when it is fully, when we're able to have earned our returns and earn our capital back, we'll transfer it to Luth, back to the management of the Lagos University Teaching Hospital. Over that period, we also expect to have upskilled the level of capabilities of the practitioners, and as a consequence, we'll also build a training center along with Luth. We worked in partnership with 2 of our major equipment manufacturers who partnered with us, one of which is Varian, and the second, of course, is General Electric. But Varian and NSI have had a great partnership in working together to make sure that we deliver not just equipment and the maintenance, but also the training. And this is one of the things that makes us feel very confident that the NSI Luth Cancer Care Center will deliver to its mandate. We also have on-ground NSI's own staff, as well as Luth staff working together to deliver this partnership. Some of the equipment we have in store, as you can see on the screen, obviously the things that we're showing here today. We have some of the most both high energy and low energy linear accelerators and all kinds of machines, brachytherapy, all the departments that's necessary to make sure we deliver to this level of care is made available at Luth. It's been a very interesting ride because the capacity utilization of the machines, and we continue to install and expand the capacity, peaked at 73%, but that's just before the whole COVID incidents. And as a consequence, you've seen utilization rates come down. But we believe when COVID starts to clear, more and more people will come back. And it's a very interesting challenge because we are starting to see, and across the whole world, one of the most vulnerable groups are cancer patients who are unable to take on any other infections. And so this COVID period has been a real challenge for the center and also for our patients. And we wish and continue to wish them well and hope that we can all resume to ensure that people get the care that they need. What do we expect this investment to do? We expect this investment, obviously, to address all the issues I've mentioned earlier, provide affordable and quality care, in the country. And so far, we've been able to deliver that. We believe that our center at the moment, people are able to access care for less than a third of what it will cost them directly in going into neighboring countries like Ghana, where people used to go, or significantly less than 15% of what it will cost them, or 20% to go to Europe or to go to Dubai, go to other countries. And we have also set up partnerships with Nigerians who are practicing in the field of oncology outside of Nigeria to provide support to our professionals. And so we believe that we're beginning to get to the point where we can deliver the same level of care as you get outside of the country, as you also get at least for a significantly lower cost to our people. The second thing is obviously improve standards of our professionals. They have the right tools as they're getting trained and getting more and more comfortable using all these tools. We believe that across the country, we will upskill the entire country, especially as our training center starts to work. Luth is the first center we've built. We're looking to build many more centers, especially using our training center as a springboard to ensure that people across the country actually get adequately trained. The final thing, obviously, is economic effect. We believe that this will add significant economic value, not just to the center itself, but also to Nigeria as we provide better quality care for people. Because actually, there's a lot of focus on people who are able to go abroad for treatment. But nobody's paying enough attention to those who can't afford to go abroad, but can only afford to pay for the care. And if we're able to extend the quality of them and make them more productive in society, the economic impact will be quite significant. Here are some pictures of our centers, especially diagnostic centers. We built 2 of them so far, and we're looking to build many more of these diagnostic centers across the country. Obviously, I could not overstate the importance of diagnostics in terms of cancer care. And it's a big, big challenge in the country. And we're hoping that, especially in areas where people are not able to access some of the most sophisticated equipment they can, because we believe if we diagnose this early, we can treat it early. And so investments in diagnostics will continue significantly at pace alongside our investments in oncology. Some of the challenges, some of the points about Nigeria, I know there's a lot has been said. This is a very challenging economic environment, not just for Nigeria, but for everybody today. We're hoping that we'll emerge from this crisis. We're very confident in the strength of our economy. We've done a lot to improve doing business in Nigeria, and we're hoping that people can come in and invest in Nigeria, especially in healthcare. Some of the key factors supporting investment in healthcare, obviously, is our population. We've spoken about it earlier, 200 million people. Yes, I know a lot of it is still low-income people, but it's still a significant size of high-income and especially middle-income people that will access good quality healthcare. The second is a lot of unmet demand. Like I speak to the people who may not be able to afford to go to Europe for treatment, but can afford to pay for a center if it's delivered in an affordable manner. We're hoping that we'll continue to address those unmet needs. Of course, I've spoken about medical tourism, but more importantly for me, it's actually about working alongside government with regards to some of the enabling policies that have been put in place by government that I hope that will continue to drive investments in this area. Constraints and risks, there are quite a few. On the one hand, I speak about the large population and the size of the market. On the other hand, I'm aware of the fact that 72% are out of pocket and a significant number of people are actually middle to low income. What we have done here, quite frankly, and we're encouraging a lot of people, is to, there are foundations and endowments that are helping pay for some of this. But we're hoping for a significantly developed Nigeria health insurance sector, which I believe will drive a significant level of investment in this area for Nigerians. The other thing that is, of course, a challenge is pharmaceuticals. People are concerned about the impact of pharmaceuticals in Nigeria. And we're hoping that as we develop this sector and as we invest in this sector, we're able to add significant value. And by that, I mean that, when I think about the cost of certain oncology medications that people are unable to afford or unable to have access to, I believe that investing in this area will be an important area of interest. And then finally, of course, I know a lot has been said about regulatory uncertainty in Nigeria. I'm actually quite happy to say that in healthcare, that there's significant support for healthcare investment in terms of regulatory environments. But we're hoping that we'll continue to work and improve that. And a lot has been said about ease of doing business in Nigeria. I know it's tough. It is tough. But we're improving. Our ease of business ranking at the moment is 145 of 190. Yes, that's low, but there's been a lot of effort in making this get better. So all in all, so far, we feel very confident about the sector, feel very confident about the outlook of the sector, and we're hoping that we can continue to work with you. Anybody looking to invest in this sector, look to the NSI. Our pipeline at the moment has 14 opportunities that we're pursuing, and we're hoping that we can drive all of this. Thank you very much, and I look forward to being in touch.
Hi, I'm Dr. Chris Reddick. I'm a Vice President in Takeda's Global Patient and Scientific Affairs Department with responsibilities for leading our global health initiatives within R&D. I'm very happy to be a part of Bio Africa 2020 convention, and also very pleased to be part of this session here today with all of you to talk about partnerships. Let's go to the next slide. So today I'd like to share with you a new approach that we've been taking with our partners to focus on capacity building related to building health research and care delivery systems in low and middle income countries, and specifically in countries across sub-Saharan Africa. Now, what makes this approach new and a bit innovative is the partnerships that we have built together. So the framework for this. So we're working together with the healthcare industry. We've brought together NGOs, government and public health organizations, as well as academic institutions, and importantly, all partnering closely with local health research and care delivery systems, all with a common focus on patients, caregivers, and their communities. Now, you might say that this framework has been in place, previously and in the past, but it's really the way that we're working together that's new here. So typically, you might see partners within this framework working one-to-one, or maybe two partners working together. But here, we're really trying to work across this entire framework as a collective, so a collective intelligence, if you will, to solve problems in communities. The other important part about this framework is that instead of working transactionally, which is typically the way that the healthcare industry has worked with these kind of partners, where a grant is made, but beyond that, there really isn't input or contribution from employees with specific skill sets into these partnerships. What we've done here is we've formed knowledge sharing partnerships where each partner in this collective is contributing their unique skill sets, their strengths and resources so that we can leverage all of that going forward. Now, what this does is, in the end, I think, and what I'll show you, is it makes these programs and it makes the work that we're doing in the communities much more sustainable by having this kind of framework. And I'll show that to you in the coming slides. So let's go to the next slide. Now, when I talk about knowledge sharing being the cornerstone of this approach to partnerships, what do I mean by that? Well, you can see here that the knowledge sharing is focused on technical skill areas. So things like data management and analytics, basic research and clinical trial, knowledge sharing, also pharmacy, and even in the basic research setting like laboratory and equipment management. So across the gamut of basic research to clinical care, we have experts that sit on these project teams that are contributing their skills, knowledge, and experience in a very meaningful way. Now, the other thing that makes this framework unique is how we're sharing the knowledge. So we're doing this both virtually. So obviously this year we've been heavily relying on the virtual aspect of the knowledge sharing, but also on site in the communities where we're trying to impact patients. And this does two things. It really creates a dynamic of learning that's two-way. So traditionally, when you think of capacity building, you picture students sitting in a classroom, learning a new skill or technique, and then having to go back to their community to apply this. This framework, it's being done in the community. And with the two-way learning, those with the skills that are sharing their technical knowledge with the care delivery team, they're also learning too. They're learning about how diseases in healthcare is distributed in those communities and what the unique challenges of the communities are. They can take that knowledge back and improve how we're developing new medicines, how we're developing clinical trials, and bringing healthcare forward in the future. So we've used this knowledge sharing framework for capacity building to set up programs to support research capacity building from basic research all the way through clinical care. And I'm showing you here now a couple of examples of those types of programs. So using this framework, we've been tackling cancer care and building capacity in LMICs in sub-Saharan Africa specifically, also mental health capacity building in LMICs. We've also set up programs that are catalyzing basic research, setting up labs with equipment and the know-how to take on research that's important to those communities, and then also be able to apply for and receive research grants. And then importantly, capacity building related to the conduct of clinical trials and clinical research. We've also this year used this approach in response to COVID-19. And this was really something that we were primed to do because we had been working in areas like cancer and mental health, and we had the partnership model in place that we could quickly pivot to apply this knowledge sharing to tackling COVID-19. So as an example, we were able to set up PCR testing and also the capability to 3D print PPE. So going to the next slide, one of the knowledge sharing programs that I'd like to highlight in today's session is the African Consortium for Cancer Clinical Trials, or what we like to call AC3T. This is a partnership that started with Takeda and the NGO BioVentures for Global Health, and we've added partners along the way, both from all across the healthcare, the multi-sector healthcare spectrum. And this particular capacity building program is focused on building clinical trial capacity to address the cancer data gap in sub-Saharan Africa, as well as provide access to innovative medicines that are being tested in those clinical trials. But what we hope to do by building this capacity is really empower African cancer centers and hospitals that are really ready now to join in both local, regional, and international cancer trials. We also are working to bring those centers that are just not ready right now, but are on the trajectory to being able to do cancer clinical trial research. Part of this program is to facilitate and accelerate those centers as well. And really what we want to do is galvanize support for African investigator-led clinical trials long term. So if you'd like to learn more about this program in particular, you'll see the web link here at the bottom of this slide, and you'll be able to see a profile highlighting some of the centers that are participating in this program. So to conclude with, as you can imagine, we've learned a lot over the course of the last 4 or 5 years in implementing this knowledge sharing approach to capacity building. And I'd like to close by sharing some of those key success factors that I think we've all come to agree upon. The first one is relationship building. all of our programs and partnerships start with a focus on openness, creating openness and trust, and really trying to understand each other. Where are we coming from? Who are we? How do we get to the same space? And that can take sometimes months, even years, to fully cement a trusting and open relationship with all of those partners that I showed you on the first slide. So that's been critical to ensuring that these programs deliver their objectives for patients, but that they're also sustainable, right? So tight teams that become families tend to stay together long term. Another learning that we've taken away in our experience has been early focus on aligning your values, your mission, goals, and objectives. And this really requires deep listening to try to understand where are all the partners coming from and what are they really trying to accomplish. And we found that once we can identify the overlap of our mission, vision, and our goals in a particular place, that allows us to move very quickly towards building capacity and then ultimately impacting patients. The next area that I think is critical in these types of partnerships is developing specific project plans that outline exactly what the team is agreeing to do over the long term. So both short-term goals and long-term goals as well are critical to allow the teams to operate sustainably over 3, 4, 5 years going forward. We've also found that having dedicated teams working on specific aspects of the plan can really help, again, build that trust and reputation, but also deliver on those plans in the most efficient way. I've spoken a lot about knowledge sharing being really the secret of success in our capacity building programs, but I put that here again to stress that knowledge sharing, two-way knowledge sharing, so not just mentor-mentee or trainer-trainee, but really learning on the part of all the partners and all of the individuals that are participating in the project team. And then the final key success factor, I think, is developing very early your outcomes measures, not only having goals and objectives of what you want to accomplish for the community and patients, but really having discrete outcomes measures so that you know when you've gotten there, right? So we know when we are making a difference in those communities and for patients, we can track, we can analyze, and either reporting and publishing on those outcomes is critical for the sustainability of these programs. And then lastly, that data is used to evolve the programs over time. And hopefully you've taken away some ideas and thoughts, and we look forward to working with all of you going forward on these and other programs in the future. Thank you.
Peter Kingham from Memorial Sloan Kettering Cancer Center in New York, and I'm honored to present about our collaboration between American and Nigerian cancer physicians in a group that we have created called the African Research Group for Oncology, or ARGO. I have 3 conflicts of interest: a medical advisory board, a nonprofit organization, and a consultancy for Olympus laparoscopy. I will not speak about that consultancy. So cancer is a growing problem in low middle income countries. By 2050, 70% of predicted people with cancer will be in low and middle income countries. And there's been multiple evaluations of this, including from the Lancet Oncology Commission on Global Cancer Surgery, which concluded that the majority of cancer patients require surgical intervention. This photo is of a young 20-something-year-old male who presented about 10 years ago when I was in Nigeria with an obstructing rectal tumor. And the pattern of his disease was very different from what I had used to seeing in New York. And this individual patient led us down a path of trying to determine what are the similarities and differences between cancer patients in Nigeria specifically and in New York. So this started a partnership in 2010 between myself and Professor Isaac Alatishe, who was pictured here on the screen. And we decided to found this consortium of now up to 25 Nigerian centers with Sloan Kettering, with a focus on research, training, and treatment outcomes. And our goals are to improve outcomes for cancer patients, perform clinically meaningful research, create a model that can be replicated elsewhere, and for career development in both locations. So in order to come up with innovative research, we started with this model of the Nigerian cancer patient in the middle, and these 5 topics: epidemiology, so who gets cancer; biology, how does the cancer act; screening and diagnosis, how do I identify it at an early stage; outcomes and treatment, what happens to the patients with cancer and what are the outcomes of specific treatments; and then access. And this is specifically drawn in a circle because obviously all of these interact with each other and with the Nigerian cancer patient in the center. So I'll speak specifically about some of our screening and diagnosis studies, because that's where we're paying a lot of attention to. Because when we talk about affordable cancer diagnosis and treatment, one of the major problems is that so many cancer patients, unfortunately, in Nigeria and other low and middle income countries present very late in their disease, where cure is impossible, and even to prolong someone's life can cost a lot of money and cause a lot of morbidity. So if we look at breast cancer, for instance, in the US, the average breast cancer size is the size of a pea, usually identified not visibly, but only on screening mammograms. And because of that, the overall stage 3 survival rate is 85% at 5 years. Whereas in Nigeria, the average tumor size is the size of an orange, it's about 10 centimeters. Don't need a mammogram to identify that, it's visible. And because of this late stage of presentation, the overall survival in patients in Nigeria often much less when we compare it to survivals in the US. So to try and address this, we're looking at multiple different ways of using technology. This is the iBreast device. It's a handheld device that has 16 piezoelectric fingers on the bottom part of it that comes in contact with the breast, and it just tells you if there is some stiffer tissue beneath the device. It does not say cancer or non-cancer. So if you look at the green screens that are the output from the iBreast device, on one of them, there is an area of red. That area of red demonstrates there is something stiffer underneath the device in that portion of the breast. This would then lead to a more detailed examination with an ultrasound or a mammogram and potentially a biopsy. So this device we are currently studying in a 400-woman trial in Nigeria. And one of the downstream effects of doing more screening studies is we will find more subclinical, meaning can't feel it, lesions in women's breasts, which then need to be biopsied. Traditionally, in most locations in Nigeria, a biopsy is done in the operating room with a surgeon doing an excisional biopsy, which costs money and takes up resources and causes a much bigger cosmetic defect in the breast. So in tandem with our study in breast screening using the handheld iBreast device, we also have a program which is determining the optimal way to train Nigerian radiologists to use handheld ultrasounds to do ultrasound-guided breast mass biopsies. So traditionally, the standard ultrasound is a very large, expensive machine, whereas now, due to technological advances, there are mHealth ultrasound devices with probes that get plugged into tablets. This is some photos from Dr. Liz Sutton, one of our radiologists, in some of the training programs in Nigeria using phantoms with this handheld tablet-based ultrasound, which is really, we found to be lead to rapid uptake of this new procedure and new technology. We're also interested in colorectal cancer. We have the same problem in our Nigerian patients where the patients present often at late stage. So the answer for that is screening and early diagnosis. So we've divided screening up into 3 different ways of screening and 3 different categories of patients. FIT testing is fecal stool testing, testing for microscopic blood as a sign of colorectal cancer. And we're doing studies in average risk patients and first-degree relatives of colorectal cancer patients to see what is the utility of this stool testing in Nigeria. We also have developed a clinical screen, meaning we ask patients about their symptoms and have created a risk model with points to determine what are the highest risk features of some patients, which hopefully leads them to get a colonoscopy. And then we also have a study that is based from a NIH, US NIH grant, which is studying urine metabolites in the role of them in diagnosing colorectal cancer. This is a new technology, and we're working with a Canadian group who developed this, which is originally a mass spectrometry-based test, and our grant is allowing us to study this as a handheld test. So the approaches to colorectal cancer screening are really important for us to determine because there's no prospective trials of any colorectal cancer screening methods in asymptomatic individuals in sub-Saharan Africa. And it's really unclear how this is feasible and if really only high-risk groups should be screened. Currently, stool testing, FIT testing, is recommended by most organizations for screening in low and middle income countries, but it's really not based off of much prospective data. This is adopting high income country data to low income countries, which we know is fraught with problems. And potentially there's a unique set of issues with stool testing in Nigeria. So this is what we're trying to figure out now to answer some of these questions. We hope that we have some success with this biosensor point of care device for the urine metabolites. This is a photo. The output of this gets sent to a cell phone or a tablet. So this can be a handheld point of care device test. We're also using technology to look at a greater scale in Nigeria about the location of cancer centers. So this is using a cost distance model with geolocating software, using population density and road infrastructure data. The red areas are areas where there are cancer centers, and we're trying to demonstrate that travel times can significantly vary between them, and if there are some gaps in the country that are filled in with cancer centers, this may drastically increase the ability to access care. And finally, research is also a component of training. We have a significant number of fellowships for our Nigerian colleagues. Pictured here is Lakan Olisahinde, one of the superstars of Nigerian medicine, who completed a mostly remote master's course at Cornell in clinical research, and he's now leading multiple clinical trials back in Nigeria. And we have multiple 6-week to 3-month observerships. We're also focusing on oncology nursing and pharmacy capacity building and pathology capacity building with the American Society of Clinical Pathology. But this is a two-way street. We also want to ensure that trainees in North America also have access to appropriate training to make this a part of their career. So we have a Global Cancer Surgery Fellowship with Sloan Kettering fellows spending half their time with us in New York and half their time in Nigeria over the year. And we've had 2 Fulbright fellows who are working with us in Nigeria. The important thing is that the output from Nigeria can lead to new research questions for both the US and Nigeria. It is really key to have diverse patient populations. We know this from studying colorectal cancer biology. We're learning new things about colon cancer that we didn't know by studying Nigerian patients. And we're learning a lot about screening in high-risk populations. And we also find that disparities are really mirrored in both countries. The fear of medical institutions, barriers to access to care, a reliance on religious institutions for medical guidance. All of these things exist in both cultures, and it's important to take lessons we learn from each to apply to the other cultures. So in conclusion, Argo is focused on research and training, multidisciplinary with representatives from epidemiology, surgery, medicine, pathology, radiology. And our goal is to focus on clinically meaningful projects to improve outcomes for cancer patients in low and middle income countries. This is a photo of our group in New York. And this is a photo of some of us with much of our leadership group in Nigeria at the last symposium we were able to have in 2019. Thank you very much.
Ladies and gentlemen, it's a great pleasure to have this opportunity to present how Rwanda is delivering national cancer control objectives through research and international partnerships to this Bio-African Convention. So I'm Dr. Francois Winkins. I'm leading the national non-communicable disease program that also includes cancer control program at Rwanda Biomedical Center, which is an implementing arm of Rwanda Ministry of Health. So let me start by, giving you some few data on cancer incidence in the country. As you can see, from 2007 up to 2018, cases have been increasing, but this is mainly due to the improvement that we have done in cancer diagnosis. Because in 2007, you had only one pathology lab with one pathologist, but now you have got 5 pathology labs functioning, being run by around 15 pathologists, Rwandans, and also 20 in the country. But as you can see, in 2018, we recorded 2,800 new cases. The numbers are still low compared to WHO estimates, where in the same year, the World Health Organization was estimating 10,000 new cases in Rwanda. So we need to make sure that really we have a good awareness in the community, we have a good referral system, but also we have enough diagnostic capacity to be able to confirm cancer diagnosis. So it's really, it's a journey that we have started, and we hope that in the near future, we should be having really good data on cancer in the country. So, what do we have now in Rwanda regarding cancer prevention and control? So, for prevention, we are focusing a lot on awareness to make sure that really our people have enough knowledge on cancer prevention and cancer detection. And again, as intervention, we have initiated HPV vaccine in young girls that I'm very happy to tell you now that really we have a very good vaccination program. As of now, 93% of young girls are immunized. So really, it's a good indicator. So we should be having the incidence of cervical cancer going down in the 10 years down the road. For early detection, again, we are prioritizing women cancers, namely cervical cancer screening that we are integrating into primary healthcare settings, but also breast cancer early detection that we are doing simultaneously with cervical cancer screening, but also community checkup at health centers to make sure that people, so that we can have people at the early stage and also be able to initiate the treatment early. For diagnosis, we have really also improved a lot on this area. We have got now functional 5 histopathology labs with more than 15 pathologists. We have people also have access to CT scan, MRI for staging, but also a mammography, but also X-ray and also ultrasound that are available in all facilities. So regarding cancer treatment, we're happy now to say that we are able to provide a comprehensive cancer treatment in the country. We have got surgery, systemic therapy, but also the radiation therapy in the country. We are no longer sending people outside to access the radiation therapy. We have also prioritized palliative care, given that really the majority of our patients are presenting at advanced stage. So we have put much efforts in integrating palliative care into existing health system to make sure that people can have access to quality palliative care services in health facilities. And also we are now, we have a local production of oral morphine to make sure that patients have access to that life-saving medication that reduces pain and also improves the quality of those patients that need palliative care. Regarding monitoring and evaluation, so we have now put much efforts in having the National Cancer Registry that we do host here at RBC. We have started with the city of Kigali, but now we're also extending it to all districts in the country to have a national coverage using technology through the HS2. So again, here there are really many issues that we do see in our cancer prevention and control program. So we still think that the awareness in the community is still low. People are presenting still at advanced stage. And also we need also to have precision diagnosis, make sure that really we have got those best molecular diagnosis, histopathology is available, but also have a good staging of cancer. And this will also lead us to having a good cancer treatment program with enough infrastructure, equipment, but also human resources And again, as you all know, cancer management is expensive. We are also working on make sure that really our patients can really afford available cancer treatment services using different mechanisms, and also keep improving on palliative care services. Then we know that we should have quality data and also be doing research to be able to evaluate our interventions, informing our plans and the policies, and then be able to improve on what we are doing. And then, it's as a developing country, we don't have enough domestic resources to finance cancer prevention and control. So we need also to mobilize additional partners, additional resources to be able to have enough funding for cancer control in the country. So to be able to do this, we need to be organized. That's why we developed our first national cancer control plan for 5 years. So with a main goal of reducing cancer-related morbidity and also mortality in Rwanda. The plan has got 6 objectives. The first one, of course, is reducing the incidence of those preventable cancers, focusing mainly on cervical cancer. And also, we can also do something on liver cancer. So we need also to make sure that we have got early detection programs to be able, and also screening programs to be able to have cancer cases at the early stage. And again, and be able to make an accurate diagnosis, but also a good treatment to cancer patients. We need also to be able to provide quality pain management in the palliative care services to cancer patients. And again, as you can see, cancer information system and research are among our main objectives for this cancer control plan of 5 years. And also, we need also to be able to achieve all this, to be well coordinated, have meaningful partnerships, but also increase financing for cancer control. If you are on, I can give you some many partnerships that we do have now in different areas of cancer prevention and control. So like cancer prevention and early detection, so we're having a good partnership with Clinical Health Access Initiative in cervical cancer screening. BioVenture for Global Health, they're also supporting in this area to make sure that really we have a very well integrated cervical cancer screening program and also breast cancer detection at the primary health care level. Partners in health, they have been here for many years, so they are supporting a lot in this area. We have also Gavi that is supporting on vaccines against HPV. For cancer diagnosis, American Cancer Society, they're helping, American Society of Clinical Pathology, they're helping a lot. And modernizing our pathology labs. So we also have DVGH that is supporting a lot in this area. Partners in health, again, they are really our key partner in this, and they have been here for a long time. In palliative care, we're working closely with American Cancer Society. We have a very good program on pain-free hospital initiative. We have got Rose Foundation also that is supporting integrating palliative care services into primary health care. For cancer information system, International Agents for Research on Cancer, they are supporting on strengthening our national cancer registry. We have got the National Cancer Institute. For oncology research, Takeda is helping a lot in setting up clinical trials capacity. BioVenture for Global Health, NIH, NCI, they are also really supporting a lot in this area. Just to finish, I think our young cancer control programs in Africa need meaningful and long-term partnerships in all areas. And also those partnerships should be responding to the national needs, but also be aligned with national cancer control plans. That's why we should have strong cancer control plans. We need also, our countries need to invest more in the cancer information system to generate accurate data on the continent to be able to inform our plans and policies. We need also to be putting much efforts in operational research, clinical trials, to be able to measure treatment outcomes, to evaluate those new therapeutics for cancer on the continent. So thank you so much. That's what I had to share with you, and hope we have time for questions and answers. Thank you so much.
So that is the end of our formal presentations. I'm just wondering, is there anyone on for Q&A? Does anyone have are there any questions? Chris, Francois, I think there may not be any questions, so I think we may be wrapped up.
There's no questions, ma'am, currently.
Okay, thank you. So Chris and Francois, great presentations. I texted both Uchi and Peter just to let them know that I thought we'd go a little bit long, so we probably would not have time for Q&A. They were just planning to jump in for the Q&A because they knew they were pre-recorded. But just want to thank you both so much for great presentations and for participating. We will be working with the convention to get the recordings, and also one of the ideas that BVGH had was to take some short components and messaging from the recordings and create an even shorter highlight video to capture some key messaging from each of the speakers, and use both BioAfrica platform to promote and make that information available in a way that's more watchable than a full hour. And then at BVGH, we thought we would also push that out through some of our communication channels, including tapping into the bio team here in the United States, in Washington, DC.
That's great. Thanks a lot, Jennifer, for having us.
Yeah, no, thanks very much, Chris, for joining. Francois, great talk. Thank you very much for taking the time.
Thank you so much. Yeah, it was a good opportunity. And also, I'm wondering, so I guess you are in touch with them. So those guys, I mean, that great doctor working with a Nigerian team, that with those, I mean, devices, let's say the breast scan, is it eye breast scan, and also those portable? I think these are interesting things that maybe we can, I mean, explore more.
Yeah, I know Peter Kingham well. He's terrific, Francois, and he had some meetings with Pacifique, and they discussed kind of taking some of the what is Peter's network of clinical studies into Rwanda. But the last time I spoke with Peter, and I've just been sending him a few messages, we're going to catch up later this week. But I was thinking the same thing, Francois. I was thinking really Peter should have some sites in Rwanda. So he has, I mean, literally, Francois, he has about 5 NCI NIH grants for his studies. And I think that he could be a very strong partner for you and for Rwanda in general, because if he can start to get you engaged, his grants renew. I know he had one of his colorectal cancer grant through NCI renewed about 4 months ago based on some of the early milestones they saw in Nigeria. And I really feel that, it'd be great for RBC and for the patients in Rwanda to participate in this study. I know Peter was talking to Pacifique, so I will ask him what happened, and maybe I could suggest that we have a direct discussion with you to see how we can get at least one center in Rwanda participating.
Yeah, I think so. That would be terrific, because I mean, we'll be able to talk with him, but even where can we, are those devices, gadgets now commercially available, so that maybe if you want to purchase,
they are. So they're out of a group in India. I know the founder and the inventor of iBreast Exam, and it is a handheld device. But as Peter said, it's still being studied, and what it captures is if there's certain greater density in the breast that might be cancerous. But it's also I'm not an expert on it at all, but I've also heard that there is some error that's associated with the user. So if healthcare providers are using it, they may have a lot of false positives. But I think it'd be good to speak to the clinicians that are actually studying it and see how it's comparing against other ultrasound technologies, because it has been developed as a device to be more affordable. And, it would, if you think about the cervical cancer screening programs, if women come in with concerns about their breasts, if having this device could potentially be helpful for an early screening, just to confirm that they should come in for a full examination into Kigali. So they could be useful tools, I think, for Rwanda. So I'd be happy to, maybe Peter could talk about his experience, or Liz Hutton, the other clinician at Memorial Sloan Kettering that was in his video. She is she's a breast cancer specialist at Memorial Sloan Kettering, and she's been doing a lot of the training on breast biopsy and diagnosis. And I know she's very involved in the iBreast exam study too, I believe. So maybe we could connect with both of them so they could provide you with their thoughts on, the pros and cons of the device and how you might be able to use it in Rwanda. And then I can certainly connect you with the, the founder of the company, who is, I think he did his PhD in the United States, and he's back in India now with his company.
That would be great. So I would be happy to get connected to them.
I'm happy to do that, Francois. And I also think Peter, as I remember, was talking to, is it Dr. Edward at King Faisal? Is there an Edward? Yeah, he's a surgeon.
He's a urologist.
Okay. I think Peter was talking to him. I remember at the aortic meeting in Kigali, that I think that they were talking about a collaboration and using King Faisal as a site. But I'll ask Peter, and maybe we can circle back and have a conversation.
I think so. Yeah, I will be able to facilitate and see how we can move forward. Because these are something interesting. I mean, that breast scan, and also, that portable, taking those probes, ultrasound probes, connect them to a tablet. It could be cheaper than purchasing that for ultrasound machine. And yeah, these are
absolutely yeah. And I think a lot of sites are going toward the handheld ultrasounds. The more low, I think the accuracy's gone up in the technology, but they're more portable, they're easier to use. I know Philips has a handheld device. I don't know if you've seen that device, but I think that looking at what iBreast exam is and how it compares against the other devices would probably be very, very useful for you. Yeah. Mm-hmm. So I'll set up a call with Peter, Francois, so we can ask these questions and discuss these points. What I also thought, though, Francois, was interesting. Oh, I think I better jump on the other. I think I've got another panel session I need to jump on.
Yeah.
We should. Well, let's catch up. But I better jump in.
Yeah. We catch up with it. Okay. Thank you.
Okay.
All right, Francois, Jennifer. Good to see you both.
Thank you, Chris.
Thanks for a good session.
Thank you.
Thank you. Bye-bye.
Bye.